there was no palpable lymph nodes. And they were randomized. At that time, all patients were getting axillary lymph node section. So it didn't matter if they were clinically no positive, clinically no negative, they would get an axillary lymph node section. But they were randomized to receive a procedure called a sentinel lymph node biopsy, and then all of those patients afterwards would be sent to an axillary lymph node section immediately, versus receiving a sentinel lymph node biopsy alone if their sentinel lymph nodes were negative. This procedure, that's where sentinel lymph node procedure was created. It started not in breast, it actually started in melanoma a few years before then. And the idea behind the sentinel lymph node is maybe lymph node spread has a pattern. You don't need to remove all of the lymph nodes. Maybe the cancer will go to the first, second, third lymph nodes, which we call the gatekeepers of the breast, before spreading to other lymph nodes. And if those first lymph nodes are negative, maybe we don't need to remove 30 lymph nodes to prove that. Maybe if we just remove the first 2 or 3 and prove they're negative, that means that the rest of them are negative too. So that's what they did. They would inject a dye in the breast, so it was dual tracer. They use lymphedema, which is a blue dye. Some people use methylene blue, but for the trial it was lymphedema. And they use technetium sulfur colloid, which is a radioactive dye. They will inject that dye in the breast. That dye would travel to the lymph nodes. They would find the lymph nodes that had the blue dye and the technetium. They will test those lymph nodes, and then patients will be randomized to either, if the lymph nodes are negative, not do anything else, and if the lymph nodes are negative, be randomized to an axillary lymph node section. The identification rate, so they were able to identify 97% of sentinel lymph nodes. So that means the procedure worked. They were able to find lymph nodes. And the false negative rate, so false negative rate means having a negative sentinel lymph node, but at the time of the axillary lymph node section, they found cancer. So was 10% if 2 or more sentinel lymph nodes were removed. And there was no difference in axillary recurrence, and no difference in overall survival or disease-free survival. Kind of similar idea that the NSABP B04 showed. No difference in survival between different types of axillary surgery. And most importantly, sentinel lymph node biopsy caused less morbidity, less lymphedema, less pain, less sensory loss. So after this trial here, patients with clinically node-negative disease would then undergo sentinel lymph node biopsy procedure and not axillary lymph node section. Sorry, I did backwards. Then we move a little bit forward. And I remember this trial here, what is the Agazog Z11 trial, because I was about to finish my breast surgery fellowship when the trial started, which was actually a good thing, because today, breast surgery fellows in the US, they do little to no axillary lymph node section. We have to look for patients to do axillary lymph node section, because this trial changed it all. So remember, the B32 was for patients that were clinically negative, that we did a sentinel lymph node, and the sentinel lymph node was negative. But the patients that had a sentinel lymph node that was positive, all of those patients were still receiving an axillary lymph node section. In this trial, the Agazog Z11, what it did was for patients with early stage disease, so clinical T1 and T2, clinically negative, who received breast conserving surgery, so lumpectomy and radiation. And during surgery, they were found to have 1 to 2 positive sentinel lymph nodes that were they found in surgery positive sentinel lymph nodes. They were randomized to either receive an axillary lymph node section versus just do the sentinel lymph node alone. And what they saw again was that there was no change in local regional recurrence or survival between the two groups. The difference, the only thing, the problem, if I have to say, with this trial, that there were no mastectomy patients, so this was all breast conserving surgery, so lumpectomy and radiation. And the majority of patients had micromets. So we couldn't tell if not doing an axillary lymph node section would work in mastectomy patients or in patients other than micrometastatic disease. That's the reason why this other 2 trials existed. I'm not going to go into that much detail in the other 2. So the Emerald trial was actually the same concept, randomizing patients with 1 to 2 sentinel lymph nodes to either receive an axillary lymph node section or axillary radiation. And those patients actually the trial included mastectomy. And the lymphedema rate was significantly less with radiation as opposed to an axillary lymph node section, and there was no difference in survival. So after the EMERALD trial, we started offering no additional axillary lymph node surgery for patients who had a positive sentinel lymph node after a mastectomy. And then the CENOMAC trial, they also included T3 tumors, included more patients with mastectomy, so 35% of patients had mastectomy. Patients that had extranodal extension, so 1/3 of the patients had extranodal extension in their pathology, and also about 30% had a lymphovascular invasion. So based on those 3 trials, we started omitting axillary lymph node dissection in patients who were clinically N0, and later during surgery were found to have 1 to 2 positive sentinel lymph nodes, and they were small tumors undergoing breast-conserving surgery, patients who had micrometastatic disease, patients with larger tumors, extranodal extension, male patients, and also patients that were undergoing mastectomy. But then what happens, especially to patients that do not fit that criteria? So that's where the problem lies today. So for instance, I have a mastectomy patient, and the patient needs to have post-mastectomy radiation in order to have axillary lymph node dissection omitted. So how about if I have a mastectomy patient that we don't think needs post-mastectomy radiation? What do we need to do? Do we remove then all the remaining lymph nodes with an axillary lymph node section if they have a positive sentinel lymph node, or we don't do anything? So each institution has their own criteria to offer or not offer post-mastectomy radiation for patients who are clinically node negative and they undergo upfront mastectomy. So for instance, at MD Anderson, this is the criteria that we use. So patients who are younger, who has more than 3 positive lymph nodes, who have lymph nodes with a T3 tumor, who had a recurrence score, genomic score that's more than 18%. So I'm not going to go through all of this list. So all of those patients here would receive post-mastectomy radiation. But also patients who are pathologically node negative and have high-risk features will also receive post-mastectomy radiation. Today, if you're not receiving post-mastectomy radiation and you have more than 3 positive lymph nodes, or if you're not 1 to 2 positive lymph nodes, or if you have more than 3 positive lymph nodes, those patients will always get an axillary lymph node section. So 1 to 2 positive lymph nodes and you're not in any of these criteria here, so not receiving post-mastectomy radiation, the standard of care is still to have an axillary lymph node section, or we found more than 3 positive lymph nodes on a sentinel lymph node biopsy. But with that, we also started requiring less resources, right? Because before we had all these trials, and we were offering axillary lymph node dissection for all patients that had a positive sentinel lymph node. At that time, that's when I was doing residency and fellowship. We used to do frozen section in all axillary tissue, right? Because we would take the patient, do the sentinel lymph node biopsy, we do the frozen section. If the frozen section was negative, we were done. If the frozen section was positive, we would do the axillary lymph node section. But with those trials now saying that we don't need to do axillary lymph node section in all patients that have clinically pathologically node positive disease, we stopped doing frozen sections in those patients. And what that does, it modify resources, improve utilization of resources, improve utilization of operating rooms, because frozen sections take time. So if you're waiting for a frozen section to happen to know what's your next step, you're staying in the operating room for another 20, 30 minutes minimum. If you're just not doing the frozen section, you can move on and go to the next surgery, and it's so more efficient. And so now we don't do frozen section anymore in some instances. We defer that to the final pathology to then figure out if that patient needs post-mastectomy radiation, or need a completion axillary lymph node section, or need nothing. And then we started thinking about, as you can see, we're decreasing and decreasing and decreasing the amount of surgery. Then other people decided to think, how about not doing sentinel lymph node biopsy at all? The people that started thinking about that were actually based on these 2 trials. So the first trial they were not looking at omission of sentinel lymph node. That was not the point. The first trial were actually older patients, older than 70 years old, with small hormone receptor positive tumors who are actually randomized to radiation versus no radiation, just tamoxifen after breast conserving surgery. And those patients actually had a really low risk of axillary recurrence, even if they did not have any axillary surgery. So some of those patients didn't have any sentinel lymph node at all, and the risk of axillary lymph node recurrence was super low, was 3%, compared to the people that have a sentinel lymph node biopsy. So with those trials, the idea of which patients would benefit for no axillary surgery at all started. And then we have with the most recent trials regarding axillary surgery, which is the SOUND trial. In a later slide, I'm going to install the ENCIMA trial. So the SOUND trial, which was published less than 2 years ago, actually it was a non-inferiority trial. It accrued about 1,500 patients at any age, but as you see, the majority of them were postmenopausal and early stage breast cancer, clinically no negative, and that's really important, by ultrasound. The ultrasound was used for this trial. It was not only, until this trial, we would consider patients clinically no negative only if they had a negative clinical exam. Starting on the SOUND trial, we started using ultrasound of the axilla to prove that the lymph nodes were normal. And those patients were then, they received breast conserving surgery and radiation, and they were randomized to either receive a sentinel lymph node biopsy or no receive surgery in the axilla at all. So basically, you do a lumpectomy in patients older than 70, no axillary surgery. The majority of patients were hormone receptor positive. Almost 100% received radiation. And the patients that were eligible received endocrine therapy. So this is just to show the importance of the multidisciplinary treatment. You cannot omit everything. I always tell my patient, you can cut so many corners during cancer care. If you cut all the corners, that's not a good treatment. But you can cut some corners. So here, even though we did not perform surgery in the axilla, patients received radiation, patients received endocrine therapy. And with a follow-up of almost 6 years, there was no difference in the disease-free survival, overall survival, or axillary lymph node recurrence. So axillary recurrence in the no sentinel lymph node biopsy group was less than 1%. So what happened? After SOUND trial, patients that are older than 70 with small node, clinically no negative tumors on ultrasound and are hormone receptor positive, HER2 negative, and are planning to receive endocrine therapy, we are actually not doing sentinel lymph node biopsy anymore. We're just doing a lumpectomy. So what are the considerations that we need to take into account to be able to implement this trial in other places? The fact that it needs to have that place needs to be doing axillary ultrasound to be able to include patients on this trial. And of course, the systemic therapy was based on the biomarkers of that tumor. And then last, this was published literally 2025. I think it was like a month ago. The ENCIMA trial was a European trial, also looking at non-inferiority for patients with for omission of sentinel lymph node in small tumors. They also include T2 tumors in this trial, and patients received breast conserving surgery with radiation. Most tumors were less than 2 centimeters. Most of them were hormone receptor positive, but a little bit different than the SOUND trial. The population was a little bit younger, was 65, the majority of patients. And that also showed that between the arm that received a sentinel lymph node biopsy and the arm that didn't, there was no difference in disease-free survival and overall survival. And there was lower incidence of lymphedema. The no lymph node surgery had less issues with mobility and less pain. So today in medicine, we look a lot, and you guys talked about this morning, talking about quality of life, which is really important for cancer patients. We look at a lot with what we call patient-related outcomes, which is kind of quality of life measures. So this is what is important in omitting any sentinel lymph node surgery, because quality of life and those patient-reported outcomes are better. Just a kind of if about this trial is that there was not a lot of patients with lobular histology. Everyone knows that lobular cancers tend to be a little bit harder to find on lymph nodes, tend to be a little bit harder to see on imaging. So we didn't have a lot of numbers with lobular cancer to say that this would work also in lobular cancer. But today, like in my practice, this just got published, so at MD Anderson, as you all probably heard a million times, we need to do, everything is done in a multidisciplinary fashion. So every time we change a standard of care, that needs a multidisciplinary discussion. So today for patients 70 or older with hormone-positive small tumors undergoing breast-conserving surgery, we do not do sentinel lymph node biopsy anymore, and we are hopeful to discuss extending that to younger patients. So
recording stopped.
This is just kind of a good table showing the difference between the two trials. There were some patients in the Encima trial that were actually even younger than 50. We do not do omission of sentinel lymph node biopsy in patients younger than 50 because premenopausal patients, if they have a positive lymph node, they would most of the time receive adjuvant
recording in
chemotherapy.
progress.
So that is, that's important information. So the lymph node itself, it's not a treatment, but it's actually a staging procedure for premenopausal patients to guide what kind of adjuvant systemic therapy they would receive. And you can see that overall survival, the same, super high in those patients. As we know, breast cancer patients with, that have early stage disease have survivals at almost 100%, so 98% regardless of axillary surgery, and also local failure, so recurrent locally and in the axilla was also super low, less than 1%. So considerations when we were meeting sentinel lymph node biopsy in clinically no negative patients, in older postmenopausal patients, in patients with small tumor, patients hormone receptor positive, HER2 negative, and really important, the role of axillary ultrasound. The Encima trial also required axillary lymph node for nodal staging. Now, so we talk about upfront surgery in clinically no negative patients. We're going to talk about a little bit about upfront surgery in clinically node positive patients. And those are mostly hormone receptor positive tumors because if you're clinically node positive and you're HER2 positive or triple negative, most of those patients, I want to say all of them, except patients that are really old with a lot of comorbidities, the majority of those patients will receive neoadjuvant systemic therapy. So I want to talk about upfront surgery in clinically node positive cancers. We're talking about hormone receptor positive. So if you have someone, so remember the Z11 trial was clinically no negative. So we palpated the axilla, no positive lymph, no lymph nodes that we could see that were abnormal. But now that we're doing more axillary ultrasound, what we've been finding is patients that have like one axillary lymph node that is seen and it's abnormal, and we do a biopsy, and it turns out that that lymph node is positive. So if we go following the clinical trials that we've seen so far, those patients actually, they either need chemotherapy, right, or they need to start with an axillary lymph node section. But is that really necessary? So the question is, should we do sentinel lymph node biopsy or a procedure called target axillary lymph node section in patients that are hormone receptor positive if they have limited nodal disease? So that's something to be considered. So what are the things that we need to consider when we are offering less surgery on those patients? First thing is, we need to look at if that patient has palpable matted adenopathy versus the imaging detected one. So we're looking at burden of disease. Patients with palpable matted adenopathy should not be getting sentinel lymph node biopsy if they have a positive lymph node. They should be either receiving neoadjuvant systemic therapy or they need to be receiving an axillary lymph node section. Most of those patients who qualify to have an upfront sentinel lymph node are patients with imaging detected disease, are patients who have a small amount of abnormal lymph nodes on ultrasound. And we usually use less than 3 because the odds ratio of having additional axillary disease in patients with more than 3 abnormal lymph nodes on ultrasound is extremely high, so 20. So usually imaging detected lymph nodes, we have an ultrasound-guided core biopsy or FNA to prove that the lymph node is positive. Most of the time, at MD Anderson at least, we clip that lymph node, and if that's less than 3 abnormal axillary lymph nodes, we can offer a TAD procedure, so a targeted axillary lymph node section. If it's more than 3 abnormal lymph nodes, we usually do an axillary lymph node dissection. And the other thing is, those patients, most of them are postmenopausal, because in premenopausal patients, those patients will go to receive neoadjuvant systemic therapy. The other part of this is when we're doing accurate nodal staging, we want to use dual tracer. So at MD Anderson, we use technetium sulfur colloid and lifazurium, and we also retrieve the clipped axillary lymph node, and the retrieval is done. There's several ways to do it. The way I do it in my practice, I use a reflector, infrared reflector called a Saviscout, but it can be done with a magnetic reflector. It can be done with lymph node tattooing. It can be done with a wire. There's several ways to do that. Now, for patients, we're going to shift a little bit. We're going to talk about neoadjuvant systemic therapy patients now. So for patients who are clinically N0 and are triple negative or HER2 positive, some of them will receive neoadjuvant systemic therapy. And the question is it safe to do sentinel lymph node biopsy for patients who receive neoadjuvant systemic therapy who are clinically N0? And the answer is yes, it's feasible and safe. MD Anderson had a retrospective meta-analysis of almost 5,000 patients, and the identification rate for those sentinel lymph nodes is super high, almost comparable to the Z11 numbers. Z11 was 97%, 90 to 94%, and the false negative rate was also comparable to the Z11 numbers. Z11 was 10%. False negative rates for patients who receive neoadjuvant systemic therapy are clinically no negative, and dual sentinel lymph nodes are less than 12%. And also the NSABP-B27 also showed a low false negative rate for sentinel lymph node biopsy, and it's important. Similar to upfront surgery, dual tracer and removal of 3 or more lymph nodes. So we're always going to see, when we're talking about decreasing axillary surgery in patients who are receiving systemic therapy, or in patients that are clinically node positive, they're trying to figure out if they converted to clinically node negative. We're always talking about how many lymph nodes to remove. We're talking about sampling. We need to have good sampling of those lymph nodes to make sure that that limited lymph node removal, the results are comparable with the rest of the axilla. So we cannot remove one lymph node and say, oh, I did this targeted axillary lymph node section. One lymph node is removed. We need to remove more, because if you start removing less lymph nodes, that false negative rate starts going up. And then we are not, the lymph nodes that we remove in a sentinel lymph node biopsy or a target axillary lymph node section is not stops being representative of the lymph nodes of the remaining axilla. And now, for patients today who receive neoadjuvant systemic therapy and are still clinically node positive, those patients are the patients today that we all do axillary lymph node section. But that may change. That may change. Who knows? I'm showing something in a little bit. So clinically node positive patients, which are basically HER2 positive, triple negatives, they're clinically node positive, all of them will receive neoadjuvant systemic therapy. And of course, premenopausal women who are HER2, hormone receptor positive, HER2 negative. Why neoadjuvant systemic therapy is so important? Systemic disease, breast cancer is a systemic disease, so we need to try to treat the whole body. But when you use neoadjuvant systemic therapy, you're actually assessing tumor response in vivo. So we leave that tumor in place, and we are providing treatment for that patient and evaluating their response. And it's important because it provides prognostic information. You can tailor adjuvant systemic therapy based on clinical response. So for HER2 positive tumors, we have TDM1. For triple negative tumors, we have the Keynote 522 trial. We're adding Keytruda to the regimen of those patients. So it's really important because those patients actually, by adjusting adjuvant therapy or providing prognostic information and assessing response in the neoadjuvant setting, we're actually improving survival. We are also de-escalating more surgery, conversion of mastectomy to breast conservation. So when we talk about sentinel lymph node biopsy after neoadjuvant systemic therapy in clinically node negative tumors. But if a patient was clinically node positive and they received neoadjuvant systemic therapy, before those major prospective trials took place, we were also offering axillary lymph node section to all of those patients. But some of those patients actually had a nodal PCR, so that means there were no residual disease in the lymph nodes. So the question was, does these patients still need to have a full axillary lymph node section after neoadjuvant systemic therapy if there was a nodal PCR? So the ACOSOC Z1071 Sentina and the Canadian trial both showed that sentinel lymph node biopsy after neoadjuvant systemic therapy in clinically node-positive tumors is feasible, so low false negative rate, especially when you use dual tracer and remove more than 3 sentinel lymph nodes. The ACOSOC Z1071 also used the clip in patients with clinically node-positive disease. So by adding the clip, the false negative rate decreased significantly. So we're talking about 12% to 6%. And by clip, I mean retrieving the clip to lymph nodes. So when you biopsy, you not only do, after neoadjuvant systemic therapy, a sentinel lymph node biopsy, but you also do the excision of the clip lymph node with what we call a target axillary lymph node section. So the way we evaluate lymph nodes that are positive and are undergoing neoadjuvant systemic therapy treatment, Cotto, which was one of our surgeons at MD Anderson, did a clinical trial where she took clinically node-positive patients. They received neoadjuvant systemic therapy, and they received axillary lymph node section. And there was excision of the clipped node alone versus just doing a sentinel lymph node biopsy. And that trial showed that false negative rate by excising the clipped node alone is super low. So the way it's done, this is the way that the trial was done, and this was in 2015 when we were used to using a radioactive seed. Now you have other seeds. So before surgery, we place a clip. We biopsy the lymph node. All lymph nodes need to be biopsied. We place a clip in that lymph node. And then on top of that, you place a seed to mark that lymph node. Then the day of surgery, the patient gets technetium injected in the breast. And then what you will do is and then the dual tracer, the lymphosurium, the lymphosurium blue. And you will do the retrieval of the clipped lymph node and then a sentinel lymph node biopsy. And when we do that, this is the TAD procedure, the false negative rate can go last almost 1%. So even lower than the Z11 trial. So the important thing about TAD is the accuracy of your pre-treatment ultrasound. The TAD false negative rate starts going up depending on the number of lymph nodes that are abnormal. So most of the time we can offer TAD in patients that have limited nodal disease, so less than 4 abnormal lymph nodes on ultrasound. For patients who have more than 4 abnormal lymph nodes, the false negative rate starts going higher, so we tend not to offer. But I'm going to show in a little bit trials that are starting to extend that eligibility criteria for TAD, that's showing that even though the false negative rate is a little bit higher, there's no impact in local regional recurrence and survival. And this is a trial. So this is actually was a collaboration at MD Anderson as well. So before we used to do TAD, mostly in patients who have small tumors, had less than 4 lymph nodes on ultrasound, and we were saying, let's use dual tracer. So this study, which was published in the European Journal of Surgical Oncology, showed that TAD can also be used in patients that have higher sizes of tumor, patients with more clinically node-positive disease, single tracer, and less lymph nodes removed. And they showed that the false negative rate in this instance was also low. They just use no palpable adenopathy to offer patients TAD or not. So expanding the indications for TAD. Today, the NCCN guidelines, and that's what we always, when we're talking about in the United States cancer care, this is when you're looking at standards, this is the place that we look for to make sure that we are doing what has been proven to work in randomized clinical trials. We use the NCCN guidelines. So the way we do, we treat patients with clinically suspicious lymph nodes that they received a core biopsy, and if the core biopsy then proves the lymph node to be positive, and they go to receive neoadjuvant systemic therapy, and they have a clinical response, or basically they convert to clinically node-negative disease, we can offer sentinel lymph node biopsy or a target axillary lymph node section. If you go to MD Anderson, we will offer target axillary lymph node section. If you go to Memorial Sloan Kettering in New York, they do sentinel lymph node biopsy. But they always inject dual tracer and retrieve more than 3 lymph nodes, always. And remember when I said that today when patients have they're clinically node positive, they receive neoadjuvant systemic therapy, and if they don't convert to clinically node negative today, 2025, we're doing axillary lymph node section in all of them. But who knows, it's what we're going to be doing in 2026 and 2027. The Alliance 011202, it's a lot of numbers. This is not being published yet. This is a trial that is it's finished accrual and it's pending publication. We had an initial presentation of risk factors just presented to us 3 months ago, but the trial results are not, they're not being released yet. So what the trial is trying to find out is, do we need to do axillary lymph node surgery with axillary lymph node section in patients who have residual nodal disease after neoadjuvant systemic therapy? So the trial randomized patients clinically T1 to T3 and 1 status post on neoadjuvant systemic therapy who had residual nodal disease on sentinel lymph node biopsy or TAD. They were randomized to either receive axillary lymph node section and radiation, which is a standard of care today, versus just receiving radiation. So the primary endpoint of the trial is invasive breast cancer recurrence-free survival. And the secondary endpoint is invasive local regional recurrence. And this trial, if it's a positive trial, that means if it shows that the primary and secondary endpoints are the same regardless of the group, we may, in the future, not be doing axillary lymph node section in some patients who have residual disease after neoadjuvant systemic therapy. Today, they did a preliminary analysis of these patients enrolled, looking at factors that influence nodal disease, additional nodal disease. So right now in the trial, they have 2,000 patients that were registered and had a positive lymph node after systemic therapy. Of those that were randomized to this arm here was 841. Almost half were younger, like less than 50. Almost more than half had T2 tumors, and the majority were hormone receptor positive. So this trial may not apply to hormone receptor negative or HER2 positive patients. Most patients had more than 2 lymph nodes examined, and 80% of patients had 1 to 2 positive sentinel lymph nodes after they did the axillary lymph node section. So basically, you found the 2 lymph nodes in the TAD procedure, the sentinel lymph node biopsy procedure. When they completed axillary lymph node section, a lot of patients did not have more residual disease. So 54% of patients had no residual disease left, even after, even if they had an axillary lymph node section completed. So the factors that were associated with additional positive lymph nodes in the axillary lymph node dissection was patients that have higher sizes of tumor, so T3, patients that have a YPT3, so did not have a great response in the breast, mastectomy patients, and that the additional positive lymph nodes were also increasing depending on the number of positive sentinel lymph nodes. And in multivariate analysis, only those 3 factors remain for factors associated with additional positive lymph nodes. So to come, what this trial is going to show if we need to do axillary lymph node section in patients with the residual nodal disease in some small group populations or not. So the rationale to de-escalate axillary surgery, and all breast surgery for that matter, is because it's been shown to have no impact on survival. So axillary lymph node section has no impact on survival. Axillary lymph node section is a good staging procedure, like sentinel lymph node biopsy, like targeted axillary lymph node section. Today, in 2025, we understand tumor biology, so we know that the driver for survival recurrence is more than the surgery that we do. Has everything to do with the tumor biology, the aggressiveness of the tumor. We have improved our systemic therapy treatments. We now have, when I finished residency and went into fellowship, we only had Herceptin for HER2-positive cancers. Today we have, in our armamentarium, 3 more drugs. We have TDM1, we have Perjeta, so there's more drugs. And looking at the quality of life part, if we're not changing survival, we're not changing recurrence, why are we offering patients procedures that are more morbid? We shouldn't be doing that. So, but as I've mentioned over and over again, if you are trying to de-escalate any surgery, you need surgical planning. And that's, we need, you need appropriate, accurate clinical staging, especially in the nodal basin, doing clinical exam, imaging, nodal basin ultrasound. Patients who receive neoadjuvant systemic therapy, a quantification of how many lymph nodes were positive before systemic therapy, after systemic therapy. If you do the targeted lymph node resection procedure, mark that positive node, biopsy that mark it. So here's the 4 ways. This is an ultrasound with the clip, and that's the reflector that I use. It's called a Saviscout. This is the needle, and this is the lymph node with the clip. And this is the specimen that we remove. So when we remove the lymph node that has the clip, this is the clip here. This is the reflector, the Saviscout reflector. We want to get an ultrasound to show that the clipped lymph node containing the reflector, the marker, was removed. Features that we use to identify metastatic lymph node on ultrasound is cortical thickening, eccentric cortical thickening, loss of fatty hilum, abnormally round lymph nodes. And so if you look at the lymph node needs to be, has a kidney bean shape. If anything other than that, and the cortex has more volume comparable to the nucleus of the lymph node, that's considered an abnormal lymph node. So those lymph nodes need to be biopsied. And then, of course, if you're doing a target axillary lymph node section, they need to be marked. And again, I mentioned really fancy ways to mark sentinel targeted lymph nodes and clipped lymph nodes. There's a simple way to do it, and Dr. Brahma and I talked about that a lot, which is doing tattooing, carbo-tattooing, which is simpler than putting a reflector. So why is it important to be able to quantify lymph nodes on ultrasound? Because false negative rate on clinical exam is super high. So if you do a clinical exam and the clinical exam is negative, 45% of the times, patients that have additional nodal disease may not have that discovered on clinical exam. The lymph node, ultrasound with FNA of abdominal lymph nodes has a high sensitivity. It's not 100, it's about 80%. Specificity is 100, and has a okay diagnostic accuracy. There's still some high false negative rates. What that means is you do an ultrasound, you do a biopsy, the biopsy is negative, and that lymph node was actually positive. So in 11% of the time, in good radiologists or sonographers or surgeons' hands, that false negative rate is about 11%. And ultrasound is really good to identify large metastases, but you can see that the identification rate starts decreasing if the metastasis foci is really, really small. And that's the major issue that we see in lobular cancers. Lobular cancers, because they don't have a true metastatic deposit, sometimes you have this false negative rate is a lot higher than 11%. Multiple times at MD Anderson, I have a patient, a radiologist does the ultrasound, they say, oh, their lymph nodes are negative. I take them to surgery, to upfront surgery, because they're clinically no negative. They have like 15 positive lymph nodes, and nobody saw it. So this is just, as I've mentioned, localization techniques, wire, intraoperative ultrasound with clip, and then all the other markers. This is a tattooed lymph node here, so with carbon suspension, so that helps. That also can be a way to localize. And just a summary, I know we've talked a lot about different scenarios. So sentinel lymph node biopsy recommended for clinically node-negative patients who undergo upfront surgery with micrometastatic disease. In clinically node negative, if they have 1 to 2 positive sentinel lymph nodes and they are going upfront breast conserving surgery with radiation or mastectomy if PMRT is indicated. And sentinel lymph node biopsy, or TAD for that matter, is still indicated for patients with clinically node positive disease who convert to a nodal PCR after neoadjuvant systemic therapy. We're still doing axillary lymph node dissection, inflammatory breast cancer, locally advanced breast cancer. We don't do sentinel lymph node. I had, a couple of weeks ago, a patient with a T4 tumor. Radiologist read, oh, the patient has a completely normal axilla. I didn't feel comfortable doing an axillary lymph node section. I didn't even do a sentinel lymph node. I went straight for an axillary lymph node section. She had like 18 lymph nodes that were positive. So axillary lymph node sections still have their role in locally advanced breast cancer. And that's really important in here in Indonesia when you have a lot of patients with locally advanced breast cancer. Probably sentinel lymph node biopsy is not the way to go. Patients with residual disease after neoadjuvant systemic therapy are still receiving axillary lymph node section. In some patients with clinically node-positive disease and having upfront surgery, you can consider TAD and sentinel lymph node if you can quantify that burden of disease is small. But if you're not sure about the burden of disease, you need to do an axillary lymph node section. And of course, this is kind of to be discussed. That's where the multidisciplinary team gets, it's so important. Patients with small tumors who had receive segmental mastectomy or lumpectomy with radiation, and you do a sentinel lymph node, you find 3 sentinel lymph nodes that are positive. Do you do an axillary lymph node section in those patients? That's when you go back and talk to the medical oncologist. You have this tumor board that you guys did today and discuss this. Should I go to do an axillary lymph node section or sentinel lymph node biopsy is enough? So this is special for Dr. Brahma. This is a surgery for prevention of lymphedema. So lymphatic preservation with axillary reverse mapping. So we talk about all types of axillary lymph node surgery. And those surgeries, depending on this kind of surgery, by that axillary lymph node section, has a lot of increased rate of lymphedema. So an axillary lymph node section patient who receives adjuvant radiation, rate of lymphedema can go up to 40%. Lymphedema is a morbid condition, has no cure. Patients have increased arms, the size of the arm. That affects their quality of life tremendously. So back in the days, and still now, we offer compression sleeve, and that works really well. But also, some smart people started to think outside the box, and I think that's how medicine evolves, is thinking outside the box. Is there anything else we can do to decrease the risk of lymphedema? So today, there are 2 procedures. There are procedures for treatment of lymphedema, where you can do lymphatic transfer, but there are preventive treatments for lymphedema that involve surgery. And one is called an axillary reverse mapping, and the other one is called lymphatic reconstruction, which is the famous lymphovenous bypass procedure. The axillary reverse mapping involves, at the time of the axillary lymph node dissection, you inject blue dye in the upper arm. That blue dye then travels through lymphatics and highlights the lymph node that actually drains the arm. And that's called the arm lymph node. That's a lymph node that drains the upper arm. There are, and then when you do you're doing also a technetium in the breast, and you can see that this lymph node can actually also capture the technetium. Some lymph nodes just drain the arm, so that's called the arm lymph node. Some lymph nodes capture technetium that's injected in the breast and the blue dye that is injected in the arm. That's called the crossover node. So it drains both the breast and the lymph node. So there are crossover drainage in about almost 20% of patients. So in 20% of patients, the arm lymph node is also draining the breast. And there's some studies showing metastatic arm lymph nodes in up to 50%, 43% of cases. So there's the procedure of the axillary reverse mapping. When you are preserving the blue node that drains the arm, some would say that it may not be oncologically safe to leave that lymph node in place, because when you have a lymph node, you do an axillary lymph node section, and you have a positive lymph node in the axillary lymph node content, the chances of that arm lymph node to be positive is almost 20%. So it's really high. And then, so you're leaving a blue lymph node that has a higher risk of being positive. And also, in patients that have an arm lymph node that is positive, 70% of those patients have PN2 disease, so have additional burden of disease in the lymph node. So leaving the arm lymph node based on this study and those numbers may not be oncologically safe. So what we do something different. We inject the blue dye in the arm. That blue dye, you can see the blue node here, and you can see the blue channel right here. We actually remove the blue node as part of the axillary content, and we save this tiny, tiny hair-like channel as long as possible. And then our colleagues from plastic surgery, using a microscope, they do an anastomosis between the blue node, and here, this is one of my patients. I found 2 blue nodes, and this is the second one that I found 3 blue nodes. And basically, they inserted the nodes, made 3 to 1, and connected to a vessel. So this is a microscopic picture. This, as you all know, using microscope is a really, really intense procedure. And you don't have microscopic, microvascular surgeons in every corner of this earth. So when you're offering a procedure such as this to prevent lymphedema, and that requires a lot of resources, if it's requiring a lot of resources, that's going to generate disparities, right? Because if you're going to a small hospital that does not have a microvascular surgeon, you're not getting this procedure. You're getting lymphedema. So because of that, we're trying to figure out ways to do this bypass in a more simpler way that does not require microvascular surgeons. So there is, again, another trial, which was a randomized control trial. See, like everything that I do that we're changing care, there's a randomized control trial. This is like the story of my life in those numbers. It's crazy. A randomized control trial that they actually randomized patients to receive the arm procedure with lymphatic reapproximation. So you don't need a microvascular surgeon. A general surgeon can do that. You just reapproximate the 2 lymphatics and you tie them. And the primary outcome will be lymphedema. Now, we don't have those results yet. So to be determined if you need a microvascular surgeon to do these connections, or if a general surgeon can do it, or someone that doesn't have microvascular training. And this has just been shown, it's a recent paper showing that microvascular lymphovenous bypass works. So in this study, it shows that patients with axillary lymph node section that did not receive a lymphovenous bypass had an lymphedema 50% of the time, with the lymphovenous bypass, the number is down to 12%, and that's statistically significant. At MD Anderson, we are still accruing patients. We're doing a similar trial. The last time we talked to the plastic surgeons, our numbers is about 15%. Our patients are a little bit more, they're more morbid, so they are overweight, so our numbers are a little bit higher. But we still can drop the rate of lymphedema significantly. So thank you so much.
Wow, so interesting. I think that it's quite a long presentation, but yeah. Hopefully our colleagues follow those all new methods, starting from the NSAPP 04 and NSAPP 32, which compare between the ALND, axillary lymph node dissection, and sentinel lymph node biopsy until with the ALND until we do the SNLB alone. But then I try to start a question before we can everyone prepare your question to share our topic today. This is a perspective of the lymph node dissection and of the lymph node management on the axillary. It reminds me from a long time ago, even 20 years ago, from the St. Gallen ever said that lymph node is an independent prognostic factor and independent predictor. Well, until now, lymph node is still being considered even in radiation and also in systemic therapy. Now, lymph node in Indonesia. I'm trying to give you some horizon about Indonesian lymph nodes. We are the rich country with having the biospecimen in this air, meaning that most of the women, our population, have got lymph nodes enlargement. So, if in the West they have got a breast cancer with a lymph node detected as enlarged, that's a problem. It can be considered this is already metastasis. But here, well, even after surgery, lymph nodes we got large. So if you just consider only the clinical lymph node, then it's a problem. But then you are trying to give a name pathological, no pathological term of the lymph node and the metastatic term. So what I'm telling you about the lymph nodes, some women, they are raising their hair on the armpit, and they got infection, and then they got the what's so-called chronic lymphadenitis, and they enlarge because chronic is getting quite still there. When they get breast cancer, that's a problem. But you are trying to get the accurate and how to do that until even the neoadjuvant, you have a TAT and then how to do on the residual nodes. So, what is your comment? I went to the baseline first.
It's really interesting that COVID was an awful thing, but COVID actually was really important in a way because for lymph node issues. So COVID vaccine causes a lot of lymph node enlargement. And when COVID happened and we started vaccinating women and the population, not only women, everyone, but women still had presented with breast cancer. We had a major issue because what happened was The women will come in with a breast cancer diagnosis, and they just received their COVID vaccine a month before, which is fine. But then they had axillary adenopathy. And for the first 6 months, we were doing a lot of ultrasound-guided biopsy because we would see the lymph node, we would see the cancer. I'm like, oh, this lymph node is super large. And then we started seeing a pattern of that being COVID vaccine. And then the radiologist started learning, as COVID progresses, right, it lasted several years, what was the feature of that lymph node that was actually representative of COVID, a reactive lymph node, versus a lymph node that was metastatic. So we could see in our institution a trend from the beginning of the COVID area where a lot of ultrasounds and biopsies were being performed because the radiologists were just didn't know what that lymph node was, and their learning curve going up, they've been able to identify that lymph node as a reactive lymph node, and that's what happened with women that have pimples and all of lymph node can react to anything. And then they were able to figure out features that were consistent with a reactive COVID vaccine lymph node as opposed to a lymph node from a cancer. And with that, they started biopsying last. So as far as the lymph node size is one of the features, but I think as the physicians and the providers that are doing those ultrasounds and seeing those normal lymph nodes that are just enlarged, and they look at lymph nodes that are actually metastatic, if they start doing biopsy, and that's where following data also helps, it's looking at what features that lymph node that is just enlarged because it's a population finding versus what features of the lymph node it's meaning cancer, and then training those people that are doing the lymph node ultrasound to be able to identify the different features. So that takes time, right? They need to be doing several ultrasounds to be able to differentiate. But the majority of time, if you're tracking those patients and if you're tracking those providers that are doing the biopsy with training and with like having data to show, oh, just the size is not that important. You need the cortical thickening. Maybe in that person that has the lymphadenitis, the lymph node doesn't have cortical thickening. So that may be a feature that may differentiate a lymphadenitis lymph node from a cancer lymph node. So that's my take on this enlarged lymph node. But we had that issue in Houston, at MD Anderson with COVID, and it was not fun, so I get it. We were doing a lot of biopsies for benign lymph nodes. But we also did the biopsy, and the biopsy was benign. Other thing that's important when you're doing biopsies of lymph nodes to make sure that you get a good sampling it's to look for lymphoid tissue. So when you do an FNA or a core biopsy, when the pathologist is looking under the microscope, they need to identify lymphoid tissue to know you're in the right place, doing the biopsy of the right area.
Thank you. Can I get another microphone? Excellent. Yeah. Having the epidemic with the COVID-19, the West learned a lot about lymph node. But we have learned even before. We got the tuberculosis, and as I mentioned, the richest country who has got the biospecies a lot is Indonesia. We are living in a tropical country. But Anna mentioned that have to get accurate analysis if how to do with the clipping and with the ultrasound technology and with the new technique. And she said every day we change our standard of care. Wow. You mentioned that standard of care, meaning that they're going so fast. But I want to answer, until there is one of a technique that we don't have to do any SNLB, don't have to do any sentinel node dissection intraoperatively, right?
Yes.
Yeah. Okay, now I want to share with others, with our colleagues, our participants here. Uh, any questions from you? Yeah, please.
Dok, mohon izin. Tanya, Dok. Assalamualaikum. My name is Budi. I come from the rural, remote area from Indonesia, in Kalimantan Selatan. I'm interested about your presentation that in we cannot, we don't have to perform sentinel lymph node biopsy if we're sure that there is no lymph node in examination, and also sonography examination. Actually, in my practice, I always do lymph node biopsy, because in my remote area, I also cannot perform lymph node biopsy, Doc. So, if there is any chance or opportunity, yeah, we don't have to do axillary lymph node biopsy, that we know it's also make a devastating complication. Do you have any suggestion for patient selection, which one that we don't have to escalate to axillary lymph node biopsy? Maybe, in my opinion, for patient from biopsy result grade 1 and old, and maybe hormonal receptor positive, HER2 negative, and also luminal A, can we de-escalate our mastectomy without perform axillary lymph node biopsy? Thanks for suggestion.
For your information, most of our surgeons in the rural areas, they don't perform sentinel node biopsy. It's still, see, maybe Dr. Bayu will help us to give our horizon, our picture about the sentinel node procedure in Indonesia. And back to the 1999 until 2004, as an SPP 32 being performed, that's my era. They have to be what is the lymph node which is considered to be cancer. Is the first, as the bluest, the hottest, the nearest, and the count, if they have equipment, but we could not. That's not affordable, so that's why Dr. Bayu has initiated the blue dye. So I think before, after that, because we want to give you our picture in Indonesia. Maybe Dr. Bayu first, then please, and then you can give.
So to address this zero, so the patients will not metastasis. And then after the validation, almost 70 patients, and then we are sure with our technique, and then we can, if you want to look at our technique that you can find in the PubMed. Dr. Samuel and me wrote about our simple technique in a video. You can download it free in the PubMed. And then hopefully you can start doing a sentinel biopsy in your hospital. So it is our aim to spread to socialize the sentinel biopsy techniques around Indonesia. And the aim is for in a hospital that don't have sophisticated technology. All you need to do is methylene blue dye, and you don't need even frozen section. I fully agree with Dr. Anna. Frozen section takes time and expensive. And I'm also working in a public hospital, not a territory like this. I don't have a frozen section facility in my hospital. So what I do, I don't do frozen for margin. I don't do frozen for sentinel node biopsy. So we select the patient and sometimes use our clinical judgment. For instance, you can use your finger. If you make a physical examination during you palpate the node and then you found something that it is suspicious, like we did with Dr. Anna 2 days ago, and then you can just simply go directly for axillary lymph node dissection. But the problem is, Dr. Samuel, I think with the development of sentinel node biopsy in Indonesia, we've been trying this to socialize for almost 10 years. And why the other colleague, and we had a lot of talk in our seminar about sentinel biopsy. I think we need to change this kind of procedure, starting at the beginning from the residency program. I think we have to start from the beginning, from our teacher, we have to change our mind. We have to train more. Let's say our training how to now I'm training Anna, our training how to perform the ultrasound guided for axillary lymph node. That's important. So we need to change. So regarding with the sentinel node biopsy, I think you can do it, and then. The other thing that limits the sentinel biopsy is the blue dye itself, the methylene blue dye. I know we don't have several patients of our colleagues asking about where's the methylene blue dye, and we already asked the pharmacy here in Darmais to create our own methylene blue dye, so we can deliver. So about 1 month ago, Dr. Yarsai in Solo asked me where to get the methylene blue dye. It's very simple. I can get you from Darmais and send it to you for your patient. It's very cheap. So now I think sentinel biopsy should be done. Dr. Anna talking about that. It's more challenging, but we have to move now. We have to move now. Start from omitting or limiting the indication for axillary lymph node dissection, sentinel node biopsy, and then we can move on for that. Thank you so much. I think that's my comment.
Yeah, I completely agree with Dr. Bayu. And the other thing I was going to say is the dual tracer. It's when we talk about dual tracer, we're talking about patients that have like neoadjuvant systemic therapy, but we're talking about, as humans, we don't start running, right? We start walking. We start like crawling first, and then we walk, and then we run. So if you get like the patients that are like small, if you find patients with small tumor, you do, the Z11 did not use the lymph node. You can do clinical examine axilla is negative, a small tumor. You don't need lymphedema, Dr. Bayu said. You don't need technetium. So I'm from Brazil originally. In Brazil, we don't have technetium. We use patent blue, which is kind of a blue dye. MD Anderson was not always my life. I'm lucky enough to be at MD Anderson and blessed because we have a lot of resources there. But before working at MD Anderson, I used to work in a little small town in the middle of the U.S., and they didn't have a lymphosurium. So in that little town, I used blue dye, and it was a single dye. So what I did was you inject the 3-4 cc's. You do really compressive massage of the. That's the something as simple as massaging the breast to make sure that that dye flows. You make an incision. You look for the blue node. You don't find it's a technique, so it takes a while to build. If you don't find the blue node, you either assume that the patient is no negative, palpate the axilla. Maybe if it's no negative, you don't need to do an axillary lymph node section. If you feel something abnormal, then do. But another way for you also to kind of make sure that you're learning the technique is that what Dr. Bayu said, something really important is the validation. So each of us as a surgeon, we need to validate our own practice. So Dr. Bayu, he validated a procedure. So the procedure works. But sometimes when we are starting a procedure ourselves, so as an individual surgeon, sometimes I need to do, in that case, the sentinel lymph node. You do the sentinel lymph node, and then maybe for the first few cases, to say like, to make sure that you're in the right direction, maybe do the axillary lymph node section on those patients and see, like, is my sentinel lymph node matching my axillary lymph node section? Am I my technique right? But this is simple. Methylene blue, injecting the breast, massage it. You will see the blue channel. I had another picture. You can actually see it's blue. It's super blue. If you massage the breast, you open, you see something that is blue, there's no looking around. You take that lymph node, and then you look for other blue nodes, and then you send it, and then you close it. And the more you do it, the more confident you are to find those little channels. But I would start, if you find someone with a small tumor, older patient, that's not young, that you need that information of the sentinel node really accurate, hormone receptor positive, that would be like the most straightforward patient to start that procedure. But then as you evolve and you learn how to do the procedure better and better, the sentinel lymph node can be in triple negative, in HER2 positive. All of those, if it's clinically no negative, it's clinically no negative. You can do a sentinel lymph node. But it takes time. It takes time. And the resources are it depends on where you are. But if there is availability of a modified blue agent, like here and Darmais, and that can be shared with other facilities, that will be a way for other places to start doing sentinel lymph node as well.
Thank you. Yeah, actually, we ever offered like a formula how to audit for validation yourself. But I think, maybe next time we can discuss about that. But today, the Z0011 it's getting so advanced, so getting further until there is a differing the frozen section. Here I'd like to have my colleague from the trainee, Dr. Adrian. I think, can you give your comment about this is so much advanced, yeah? Even intraoperative, we don't have to perform the frozen section. Yeah. Developed for the Z0011. Okay.
Check. Yeah, thank you, Dr. Samuel. Thank you, Dr. Anna, for the wonderful presentations. It is always nice to see a lecture describing how the historical changes, especially in the axillary surgery. Oh yeah, my name is Adrian. I'm a surgical oncologist trainee. We do a lot of breast surgery in our hospital. Maybe I want to ask about your last clinical trial, the one that for the prevention of lymphedema that can be done by the general surgeon. What is the procedure is actually like, the procedure for lymphedema prevention? And the second one is, why did you restrict the patients for the T1C? The criteria for the for the patients. Trial that you said that you described for the prevention of lymphedema. Okay, okay, and maybe for more philosophical questions, we see that in breast surgery we see a lot of the de-escalations. We see more and less radicalities for us surgeons in managing breast cancer. In your opinion, where is the directions for us to develop a new technique or new perspective in managing breast cancer for us as a surgeon? Thank you.
So the technique with for the lymphatic reconstruction without the plastic surgeon is basically you usually inject 3 cc's, and usually inject Profesor, which is a blue dye. The methylene blue dye don't that methylene blue can cause skin necrosis. So if you inject that methylene blue dye to do the arm, I don't know what I think it would probably cause some issues with the skin. I've never done it. So usually you don't. When I started, because I learn it as I go too. So when I started, I used to do just one injection, and I would get like one channel. So what I started doing, and then I looked, and my other colleagues were doing that a long time, and I just didn't pay attention. So you actually inject in several locations and kind of make a line. So in that way, you have several channels that actually lie blue. And those blue channels are usually in the same location. It's kind of in that lateral aspect of the arm. So when you're doing an axillary lymph node section, like you find the axillary vein, that's kind of, you go slow in that part, and then you find like the pectoralis muscle, go deeper, serratus, and then you find your long thoracic, you find your thoracodorsal bundle, and then those parts you're super slow, right? Because you're trying to find the vessels and the structures. But the lateral part where the latissimus is, that's the part that I like. Oh my God, this is going to take me 5 seconds, because you go like, because there's nothing there. Like, there's nothing. That's where you need to stop, because that's where those channels are. So now my surgery takes a lot longer, because the part that I used to go super fast, now I have to go super slow to find those blue channels. So what you do is, like, in that lateral part where the latissimus is, with literally going towards the arm, that's where the channels will be. So I find the channel, and I start walking towards the lymph node. And you will see that channel, blue, going all the way to the lymph node. And you try to follow all the way so you can leave a long length of blue channel. You don't want to cut that the lymphatic channel super short. So I literally track that. And, I started wearing glasses, and I blame that procedure, because the channels are so small. And I'm like this. And then you literally get your little debaki. I usually use an instrument that they use for microvascular procedure, because it's so tiny, those channels. So I follow all the way to the blue node. Then I clip that, I separate that, and I go, and you start going deeper and deeper, and you're going to continue to find more channels. So you separate as many channels as you can. It's usually, if it's too thin of a channel, that channel probably won't be good for anastomosis. So you need some thickness. You need to be I call it like a healthy channel. So once you separate those, in the lymphovascular bypass procedure, then you save a vessel, and the plastic or the microvascular surgeon does the microvascular connection. For the arm procedure alone, what you do is you basically get a 4-0 vicro, and you get that blue channel, and you actually connect side by side with another lymphatic vessel. So you do like a side to side, and you tie it. So the idea is that the channels will kind of grow towards each other, and the path will form. So it's a lot simpler than you using the microscope. The true question is, does it work? Because when you look at that picture with the microscope, that's a really detailed anastomosis, right? You can see the end of that channel being like intussuscepted to the vessel. That anastomosis is an open anastomosis. So when you do a side to side, and you tie that channel with a little with a tie, what that will happen. And I think that trial will show us, like, does this work? So are we just like tying channels and that's not doing anything, or are we tying channels and that's decreasing lymphedema? So the way you do is you get the channel try to make it as long as possible. The axillary lymph node section procedure takes a little bit longer because you are saving all of those channels that you just zap it through it, that you're like, do not care because you're removing. Those are the channels that you do care. Those are the channels that you need to save. So it's a little bit of a tedious procedure, separating each channel so you can make the connection. Does that explain? I can draw it. I'm not really good at it. I like to draw those things sometimes. And then the other question is the future, like doing new techniques. It's a challenging because I think probably if it's a challenge, it's a good challenge, because if you continue to find early cancer and you're de-escalating surgery, I may be without a job soon, which is not a problem because I have a plan B. I'm going to sell coconut at the beach, so I'm good. But I think there will still be a role for surgeons. I think there will be a role for surgery in locally advanced disease. Those diseases, recurrent disease, you know, those weird recurrences that you have, chest wall recurrence, there is still going to be a role for us in locally advanced disease. And I think technique and trying to find new procedures, I'm not really good with innovation. When I see people like creating new things, and I'm like, why didn't I think of that? I'm always that person that asks, why didn't I think of that? Because I'm not really good in creating things myself. But I think it's thinking outside the box. And that's the beauty of being here in Indonesia, is because all this lecture that I said, and Dr. Samuel here make a point that it's the locations are different, and I'm learning a lot during my week here, and I'm here to learn as well, because some things that I've mentioned over there, they sound really great on the PowerPoint slide, but then when you go to reality, it doesn't work. So I think the innovative thinking that comes from the surgeons that are seeing the problem, and like, how can I go around that? How can I make this work in my reality? And I think the beauty of being here in Indonesia and seeing all of those different things happening in miles away in the US is, how can we adapt and adjust to make this a reality for you, and maybe a different way. But that's where the thinking outside the box and the innovation that new surgeons that are being training, that's where you need to think. You may not have exactly the same, but Dr. Bayu, to me, is a perfect example, and someone that I look up to, is looking at how he sees things and how he's an innovator. He looks at the challenge and he sees a new way to do things, and he created this camera. I could never do that. But I was in the OR with him the other day. I'm like, there's this camera and shines a lymph node, and there's another way to do a targeted dissection. So I think for Indonesians and for surgeons in Indonesia, it's a beautiful time, because you guys are in the cusp, in the trenches of doing, like, creating new things.
Is there any questions? If not, I will point. Yeah, please.
Thank you, Dr. Anna. I'm Yustia Tuti, nuclear medicine physician in Darmais Cancer Hospital. We can do sentinel lymph node scintigraphy in Darmais, but now I think it's rare done, because maybe the most of patient come to with advanced stage. But I want to ask you about how is your experience with using sentinel lymph node scintigraphy with TC1990 and sulfur colloid in MD Anderson. You do you use both of dual tracer with TC 1990M sulfur colloid and blue dye? Thank you.
So for those patients that have neoadjuvant, node positive, that I'm trying to do that sentinel lymph node biopsy for neoadjuvant patients, I use the dual tracer. Upfront surgery patients, sometimes I do, because the way we do it at MD Anderson, the practice is the patient goes the day before to nuclear medicine. The nuclear medicine injects the dye, and that's some of us. Some of us, we can inject, we have a license that we can inject the sulfur colloid dye ourselves in the operating room. So some people just inject the sulfur colloid in the operating room. I like to see the lymphoscintigraphy. So my patient goes to nuclear medicine the day before. They inject the sulfur colloid, the technetium sulfur colloid. I see the lymphoscintigraphy, and if that lymphoscintigraphy, you can see that node like really light up, right? And if I can see a really true node capturing that technetium sulfur colloid, sometimes I don't even inject the blue dye. I just use the sulfur colloid in upfront surgery. Another situation that I don't like to inject the blue dye is when I'm doing nipple-sparing mastectomies. I had one case, it just took me one case. I injected the blue dye. The patient had a permanent blue nipple for 6 months. I almost died. The patient was fine. She's like, oh, I have a blue nipple. I'm like, oh my. And so I stopped using blue dye after that. So I usually just use the technetium sulfur colloid with nipple sparing. But we have good experience. It works. And sometimes when it doesn't work is because either someone had surgeries before in the axilla or in the breast, or if patient has actually bulky disease, sometimes that lymph node, the dye won't drain, and that's just how it is. But most of the time it works really well. And you find we have the probe and we find them in the operating room. The blue dye is nice because it guides you, right? Because in the body, nothing is blue. So when you see something blue, you're like, oh, this is the lymph node. So there's nothing else that can be blue in the body. There's a vessel blue, but like looking like a lymph node, there's only a lymph node. So yeah, so I like it. And we use it a lot. I use it in all my cases. I use technetium sulfur colloid.
Scan. The one day before or this day or the day? 1 day. 1 day before. Okay. Yeah, we make marker. Yeah. Yeah. Okay, thank you.
Any more questions or comment? No? You? Okay. We are in the de-escalation era. So I'm thinking as in Indonesia with the limitation, cost-benefit analysis. Anna today, Anna has presented us quite numbers of omission of the frozen section, omission of the radiation, omission of the systemic adjuvant, even omission of the lymph node biopsy, with quite numbers of trial, sound trial, and here are TAP trial and INSEMA trial. So I think we want to hear how can we come up into that level, because it will reduce our cost. Can we perform that? So we need a collaboration to learn further for our country with the limitation of the facilities. Before Anna gives her comment or offer us a collaboration to perform a study, and also as Anna mentioned, that she is also learning study about Indonesia. So I like to ask our colleagues to give any comment first, because we will come up to that level. Even the sentinel node biopsy, it's been 20 years ago. It's so 25 years ago. It's so long that we can, and Dr. Bayu also mentioned that. Maybe Dr. Bayu first, you give our comment with this. Actually, this is the last one, but I want to ask Anna first. Will you continue the other three presentation?
The other three presentations? Oh.
Yeah.
There's more?
There's still more.
To give the breast? I'll give the breast.
Yeah. Yeah, the breast, yeah. But before that, maybe give the, about this de-escalation, those trials. Are we going to join maybe the last one? Maybe Dr. Bayu. Okay, yeah.
So I just wanted to say one thing. All of these de-escalation cases, as you can see, is for early stage breast cancer, right? Locally advanced breast cancer, you don't see anybody talking about de-escalating care for T4 tumors, N3 disease, inflammatory breast cancer. So it's really important when you're thinking about implementing a de-escalation program surgery. Any de-escalation is early detection of breast cancer. And I think that's one of the other public health arena. Patients are getting diagnosed as early as possible, recognizing signs and symptoms of breast cancer, can offer de-escalation, decrease efficiency. So early detection. It doesn't work, my mouth. Oh, here, no, it disappeared. Why is this? Oh, here, see, it's like here, but I don't. Oh, there. Okay, and, not this one. Here, this one. This one. This is going to be a quick one. I know for sake of. Order, okay? Please. I'm sorry. So we haven't seen me talk a single word about breast, so I'm just gonna talk a little bit about the breast. So similar to the axilla, remember that line with the axilla timeline? You have the similar thing with the breast, talking about breast surgery. So radical mastectomy, total mastectomy, breast conserving surgery with the NSABP-B06. Then you started breast conserving surgery for DCIS, stage 0 breast cancer. So then breast conserving surgery with multicentric disease. We didn't know that we could do breast conservation in patients with multiple areas of cancer. And then we got to the most recent ones, which is the COMET trial, and that's what I'm going to talk to you guys a little bit about. It's really interesting. And then the exceptional responders trial. So I know that Dr. Bayu yesterday, he was talking the day before in the OR about doing 2 lumpectomies and how to do it. And it's a challenging sometimes for reconstruction when you're doing 2 separate lumpectomies. And I'm hours of reconstruction tomorrow. But this trial, the Z11102, was basically looking at breast cancer had multifocal or multicentric disease, so multiple breast primaries in the same breast, and the feasibility of breast conserving surgery. So again, this was a single arm. So this was not a patient that was not a randomized controlled trial. It was a single arm trial. And for women older than 40 who had 2 or 3 different areas in the breast that had biopsy-proven breast cancer. One of those areas needed to be invasive. The other two could be invasive or DCIS. They needed to be 2 centimeters apart, and the maximal T needs to be a T2. So they didn't do it for T3 tumors. Any N, and they require, again, imaging, mammogram plus or minus breast ultrasound. MRI was optional. They receive upfront surgery. Oncoplastic reconstruction was allowed. And all of those patients, this is really important, they receive whole breast radiation with tumor bed boost. And the systemic therapy was at the discretion of the medical oncologist. So the primary endpoint was local recurrence. They enrolled 200 patients, postmenopausal patients. 70% of them had 2 foci of cancer, so 2 lumpectomies were done. Almost all patients were clinically no negative, but we do multiple lumpectomies for clinically no positive and hormone receptor positive. A median follow-up was over 5 years, and local recurrence was 3%. So because this was a prospective single-arm trial, they placed a cutoff at 8 of local recurrence needed to be less than 8% in order to prove that this approach would work. So it was super low local recurrence 3%. So with this trial, it was proven to have multicentric or multifocal disease can undergo breast-conserving surgery with multiple lumpectomy. That wouldn't affect their oncologic outcome. Now, this is like literally out of the press like four months ago. So this trial was called a COMET trial, and this was for active monitoring patients have low-risk ductal carcinoma in situ. So you can see how we are de-escalating care for low early-stage disease. Ductal carcinoma is stage 0 breast cancer. So most of those will be discovered with mammogram because it's usually calcifications. So this was a randomized, pragmatic, non-inferiority trial. So they wanted to basically say, this new approach is not inferior to the standard approach. Patients were accrued for 4 years, and the primary endpoint was ipsilateral invasive cancer rate. And the way that the trial was made was patients with low-grade DCIS, and by low-risk DCIS, that means either low or intermediate grade, hormone receptor positive. The DCIS, they needed to be biopsied, and if it was more than 4 centimeters of extent of disease, 2 biopsies were needed separate to prove extent. You needed 2 separate biopsies. And the patients were randomized 1-to-1 to either guideline concordant care or active monitoring. So low-risk DCIS patients after 40 either received standard of care, which is surgery, breast-conserving surgery or mastectomy, plus or minus radiation, plus or minus endocrine therapy. And that's what we do. That's what we do for the DCIS. Then the other group, they did not do surgery at all. What they did was they started patients on endocrine therapy if the patient wanted, and why this is observation, active surveillance. So they will get mammograms every 6 months. And about 800 patients were accrued, and we had the primary outcome again in breast cancer was recurrence. And the results were that the active monitoring group, so not doing surgery for low-risk DCIS, was non-inferior to the guideline concordance care. So the most patients in the guideline concordance care received radiation. In the active monitoring, only 7% of them received radiation. And endocrine therapy was also not all. You can see like active monitoring 70%, the guideline concordance care about 65%. The majority of tumors in the active monitoring, guideline concordance care group were small. And if you look at intention to treat, and this was patients that progressed. So if they did reprogress, it would be small tumors discovered. And if you look at the intention to treat analysis and the active monitoring one, the in-breast recurrence was the same. So people did not develop more breast cancers because no surgery was done. And they collected patient-reported outcomes. So they looked at health-related quality of life, psychological and emotional symptoms, and DCIS treatment-related symptoms. And the quality of life was similar between the two groups. The concern was if a patient would be in active surveillance, that means they wouldn't get any surgery. That would impact their quality of life because they would be worried about having cancer. But that did not impact. The quality of life was the same. So results, low rate of invasive breast cancer recurrence regardless of the group. 5%, 5.9% in the concordant care, 4% in active monitoring, and similar small cancers in both groups. So one approach is not better than the other based on this trial. But again, if we have only 5 years of follow-up, we need longer follow-up to see if this trial works in the long run. The other part of it is, unfortunately, because in the active monitoring group, you need repeat mammogram every 6 months, and we don't do that normally for DCIS. There is an associated increased healthcare costs, right? Because if you're doing more mammogram, you're spending more money. So that's something that you need to take into account, especially if you're trying to implement that in lower resource settings. Are you going to then do more mammograms and spend more money on the patient, or you can do surgery and have the same outcomes and with a little surgery? Breast lumpectomies are not big surgeries. And then this is actually was just published 2 weeks ago in the JAMA. So this is a trial at MD Anderson. It's called Exceptional Responders. Exceptional Responders Trial. This is also a single arm, so this was not randomized trial. So this is not randomized. For about 4 years, 50% of patients were enrolled. So we enrolled women 40 or older with T1, T2 tumors, N0, N1 disease, non-metastatic, HER2 positive or triple negative after systemic therapy. So patients with this small node negative or positive, HER2 positive or triple negative, they would undergo neoadjuvant systemic therapy. And then after they completed the neoadjuvant systemic therapy, they will be re-imaged. If the residual lesion in the breast was less than 2%, they would then undergo imaging-guided vacuum-assisted biopsy of the tumor bed. And that is a really specific imaging guiding approach that needed to be done with a 9-gauge needle, so large bore needle, in 12 cores. And the radiologist needs to document that they retrieve the clip. Because remember, when you do a biopsy for cancer, in the US we put a clip, we need to retrieve that clip. If the patient had no residual disease, so completed systemic therapy, got the biopsy showed no cancer. The cancer got all treated by the systemic therapy. No residual disease in the breast, and their lymph nodes were negative clinically, the patient wouldn't have surgery at all. Go straight to radiation. Boom. No surgery. Radiation to the breast, radiation to the tumor bed. If the patient had no residual disease in the breast, but had a lymph node that was positive, they could receive a TAT. I can see the surgeons laughing like, I'm without a job. Yeah, I feel the same. But that's why I'm going to sell coconut. So if they had positive lymph nodes and no residual disease in the breast, they could have gone to do a TAD or a sentinel lymph node biopsy and then do the treatment of the axilla separately, right? Now, if they did have residual disease, then they will go to the standard of care. Lumpectomy, sentinel lymph node biopsy, or lumpectomy, target axillary lymph node section. And the primary outcome was ipsilateral breast tumor recurrence. So they're looking at the patients that did not do surgery. The cancer in the breast recurred more because we did not physically remove the tumor bed. No. nodal, there was 0 in 5 years, 0 in breast tumor recurrence. Survival and disease, overall survival and disease-free survival, 100%. Nobody died. So this is a preliminary study. This is not the end of it. We're still only 50 patients. It's a single-arm trial. But this study actually emphasizes and highlights the role of systemic therapy in certain breast cancers. Triple-negative breast cancer, HER2-positive breast cancer are breast cancers that possibly need less surgery and need more systemic therapy to be treated and cured. So, and really interesting, 62% of patients had a complete response in the breast. So 31 patients of those 50, when they did the core needle biopsy, had no residual tumor left. So the patients, I had 3 patients enrolled in this trial. I enrolled 3 patients out of those 50. They love me because they kept their breasts. They had no scar, no nothing. So I'm their favorite person. And then last but not least, breast cryoablation. So most of the time we offer breast cryoablation for patients that are too morbid to go to surgery. So what we do is like, oh, the patient has a lot of medical conditions. They are not feasible or like ready to go to surgery. So what do we do? So most of those patients, what they would do is that we would put them on endocrine therapy if they have hormone receptor positive tumors, and they would just stay with endocrine therapy. It's not curative, but you would kind of keep the tumor in check. So the radiologist also started to steal our job. What they did was, well, what we can do is let's do an ultrasound-guided injection of liquid nitrogen in the tumor. So enroll, this was a trial, so it's a prospective but non-randomized. So there was no randomization. They just paid and just went for the procedure. So women older than 60 with focal small hormone-positive tumors that were visible on ultrasound, they would undergo imaging-guided cryoablation, and the primary endpoint were ipsilateral breast tumor recurrence. So after that tumor got treated, not with surgery, but with actually freezing the tumor, this patient has more cancer coming back in the breast. Mine was breast cancer survival, disease-free survival, and overall survival. So 194 patients were enrolled, older patients, 75 years old. Follow-up almost 5 years, and they had repeat imaging, and the in-breast tumor recurrence was 4.3% in 5 years. So lower than most of the breast-conserving surgery trials that we have, which is about most of them at like in breast tumor recurrence of 10%. Only 7 patients recur locally with a mean time of 4 years. So we do breast cryoablation at MD Anderson for both curative or most of the time it's mostly for patients that are not surgical candidates, that we don't want to put them under general anesthesia. We do this procedure. There's a few things that we need to take into account. The mass cannot be too close to the skin, because if you have a mass and the mass is too close to the skin freezes with it and dies. So there needs to be a distance from the tumor to the skin in order for them to be able to do the cryoablation. It's a really well-tolerated procedure. It's done as an outpatient in the radiology suite. So here, surgeons are more involved in those ultrasound-guided procedures. So this is something a surgeon can do. So we're talking the things that can be done, how to grow, other things, thinking outside the box. So yeah, so breast cryoablation. This is a shorter one, but that's it. Thank you all. I don't know. I'm going to leave it.
Ya, silakan Dr. Denny. Please, Dr. Denny.
Thank you, Dr. Anna. Last year, I went to the Association Surgical Ultrasound Society in Korea, like the Dr. Kinoshita, yeah, Rafaelo, radio frequency ablation without excision in breast cancer, yeah. The trial for the breast cancer only for the hormone receptor positive, yeah. And I think it's a good conclusion, yeah, like your trial in cryoablation. But now we have a modality of the vacuum assisted, yeah. We must know how about the vacuum assisted excision for the breast cancer, because in the small lesion we can excise more of the tumor, yeah, surrounding the heart tissue, yeah, and after that we choose the maybe neoadjuvant treatment, and after that radiation. I want what's your opinion in the future cryoablation, radio frequency, or maybe microwave ablation for the breast cancer? Thank you.
So at MD Anderson, we do not do vacuum-assisted removal, but in Brazil, I have several colleagues that have done trials using vacuum-assisted, and one of my really good friends, she did her doctor's degree on that, and they've shown the really good outcomes. The major thing with the cryoablation that they mentioned when they're doing that is that the freezing of the tumor creates this inflammatory response that actually helps bring lymphocytes to kill the cancer too. So it's not only the freezing of the cancer, but also this inflammatory immunologic response to the tumor. And I don't know a lot about the vacuum assisted, but I would think that less of an inflammatory response probably in the vacuum assisted. And the other issue with the cryoablation and any other of those procedures is you cannot assess margin, right? The cryoablation, that's it, you just remove it, it's by imaging, there's no margin assessment. So I think when you're talking about implementing any of those in younger patients, we have to take that into account because they have long years ahead of them. So probably in breast tumor recurrence will be higher than in this population, like the mean age was 75. So the idea is there are going to be competing comorbidities that probably will take their course sooner than any of breast cancer coming back. So I think that's if I'm looking at my practice, when I offer cryoablation to some of my patients. I usually am offering for older patients with comorbidities, even though there are some. I didn't show, this was a single arm trial, but MD Anderson, we did a retrospective review of our patients. So we do both for palliation and for curative intent. And the age was also older, but we included, there was like, I think 2 patients that were hormone receptor negative. So there was a little bit more variable, but small tumors as well. So, I think there's room for that. I just think we need to be really specific in what kind of breast cancer patients we are offering this. I probably wouldn't offer this to my 35-year-old that has breast cancer. I would feel a little bit uncomfortable because in breast tumor recurrence, that, she's 35, she's going to live another 50 years. That number is going to be a lot higher. Yeah, I think patient selection is super important. But I had a few patients that wheelchair bound, that a patient that had dementia, and they found it was even a little bit bigger tumor. It was like a 2-centimeter tumor because it was palpable. And the husband didn't want the wife to go through surgery. It would be like putting through a procedure. So we did cryoablation on the wife, and the 2 wives actually, and they did really, really well. And they love me because it's basically you're giving a treatment to that patient without having to offer surgery. We're still following them. We'll follow them long term to see what's the outcome. And that also requires additional imaging. So the cost is also a thing, right? You're doing a procedure that requires serial mammograms and ultrasound. So in a resource setting that is limited, like you're going to be using an ultrasound, instead of using an ultrasound for a new patient, you're going to be using it to follow a cryoablation patient. So you need to take some of those things into account. But I like it.
Okay. There's one more questions from the participant, because we are having the hybrid presentation. This is from the Zoom. So the question is it still necessary for having the axillary stitching after in the era of systemic therapy? And recently we know that we try to examine to know the metastasis by the liquid biopsy. Do you have any comment?
So I don't think there's any data so like out there that I know of comparing liquid biopsy with this axillary nodal status. I think liquid biopsy is something that they are using to look at risk, right? Especially kind of when you're titrating or using systemic therapy, you're using liquid biopsy. So I wouldn't put liquid biopsy and axillary sentinel lymph node in the same kind of, or axillary staging in the same equation. But I think there is a role for omission of sentinel lymph node in a lot of patients. And, you know, liquid biopsy is still out there. It's not proven. But right now, genomic testing, so Oncotype, MammaPrint, a lot of postmenopausal breast patients who have 1 to 3 positive lymph nodes, we are not using the lymph nodes as a way to predict if they're going to receive chemotherapy anymore. We are using genomic testing. So the role of lymph node surgery guiding treatment, it's becoming less and less. And with the evolution of liquid biopsy, who knows? I don't think it's happening now, but in the future, maybe comparing local recurrence, distance recurrence, and instead of using the lymph node, saying, oh, you have a liquid biopsy that shows like disease or not, and maybe we can use that to guide therapy. Maybe we'll replace sentinel lymph node biopsy. But right now, definitely genomic testing imposed today working, standard of care. Genomic testing actually, for patients with 1 to 3 positive nodes, we use the genomic testing and not the lymph node to guide systemic therapy. So patients who have 1 to 3 positive lymph nodes that are postmenopausal, hormone receptor positive tumors, if they have a high recurrence score, those are the patients that are going to receive adjuvant systemic therapy. Before, remember, it was lymph node. If the lymph node's positive, you get chemotherapy. If the lymph node's negative, you don't. That has been shifting to more a genomic approach.
Thank you. Yeah.
Hi, Anna. I'm Maulina. Yesterday we surgery together. So I am interested with the newest paper about selective elimination of breast surgery for invasive breast cancer. So in this trial, since you say 3 of your patients include in this trial, what technique vacuum-assisted breast biopsy? Because this mentioned here that image-guided VAB on the tumor bed with 9 gauge 12 course was performed after standard neoadjuvant systemic therapy. So is it image-guided means you already marking the tumor before neoadjuvant systemic therapy, or is it also done to the patient that without marking before systemic, just image-guided with ultrasound or mammogram, or what kind of image guided first? And the second is I would like to know what technique do you do the surgery of this patient, these 3 patients? VAB technique? Yeah. Oh, they. Oh, this is all complete response. But oh, I thought is there's a one with undergoing VAB. So this is frozen section to prove pathology complete response from the VAB.
Correct. So, patient has a cancer, we biopsy, prove that they have breast cancer.
Yes.
In this trial, biopsy, pre-treatment
Yes.
is necessary with a needle.
Yes.
Then you put a clip.
Yes.
Okay? So for this trial, all patients had clips.
Oh, I see.
Then they received systemic therapy.
Yes.
And then after systemic therapy was completed, they did an ultrasound again. And if the ultrasound, the measurement of the tumor was less than
2 centimeter, right? Yeah.
then they would qualify to
Yeah.
have the vacuum-assisted biopsy.
Yes.
And that's when the vacuum-assisted biopsy, 9-gauge, 12 pores. And the reason why we selected those numbers, 9-gauge, 12 pores, there was a pilot before that I didn't explain. So before this trial started, MD Anderson did a pilot where we validated the core biopsy. So what we did was, same kind of patients, received treatment, had less than 2 centimeters of residual tumor. We would do the
VAB.
core, try
Oh,
to
the core.
get the tissue, and then all of those patients would go to surgery. And then we correlated what we found in surgery and then what we found in the core biopsy. So then
Okay.
we validated the core biopsies with the 9-gauge, 12 pores is a good representative of complete response in the breast.
Oh.
So if the core shows no residual disease based on our pilot validation study, that means that there's no residual disease in the breast because we validated this biopsy core. So those patients, no residual disease in the breast, if they had lymph nodes that were negative, they don't need any surgery
Yeah.
because lymph nodes are negative, just get radiation. If they had lymph nodes that were positive, then I needed to take them to surgery to do either a axillary lymph node section or a TAD or a sentinel lymph node biopsy. But they still, they would not, the omission was for surgery in the breast, not in the lymph node. If the lymph nodes were positive, they would still need lymph node surgery.
So I would like to know why 12? Is it because since we know VAB is there is 360 degree, so it's the 12 if we put the VAB in the core of the tumor and then it's 12 times rolling like that to make sure it's.
So I don't remember the exact details, to be honest with you, of the pilot that validated this, but
Okay.
I know that before this exceptional responders trial ever took place, they tried different ways to biopsy, and the way that was actually more correlated to what we find in surgery was 12 pores. But I don't know why it was 12 and not 11. I cannot answer that.
Yes.
Or 10 or 15.
I see, I see.
But
Thank.
I know there was a validation period where they chose that number. And I bet that they looked at other ways to do the biopsy, and those other ways with smaller needles with less pores had more, didn't match. The sample wasn't good enough.
I see.
So that's
Okay.
why we got this to 12 pores, 9 gauge.
Yeah, very interesting. Thank you.
Yeah, I think we are at the end of today's presentation, and it's really very fruitful and more information and knowledge we got today. I think I'd like to give some summary that for the era of the de-escalation and updating the management of the lymph node and also the advances of the method. We are lucky that having a lot of knowledge and some technique that could be performed. And we see that how many trials been done in MD Anderson. What we are trying to adjust and to learn, maybe we could hold a collaboration with MD Anderson, we hope. And then I think Dr. Bayu, Dr. Denny, we can perform to our trial, maybe from the step by step, because we are always adjusting to our situation, our limitation. So I think Dr. Anna, do you want to have any more? It's enough for today. Yeah, and also for the participant in the Zoom, thank you for your participation, and we are end of this program, and give applause to our Anna. Thank you, Anna. Yeah, thank you. Yeah, thank you so much. I'm giving back to the.
Okay, thank you, Dr. Samuel, for being our moderator for today's event. Everyone, before we close today's event, I would like to invite Dr. Samuel, Dr. Anna, Dr. Denny, Dr. Bayu to come forward for a group photo. Sorry to speak bahasa. Untuk seluruh partisipan yang sudah hadir pada hari ini, kami persilakan untuk maju ke depan untuk melaksanakan sesi foto bersama. Boleh naik ke atas panggung, Dok, supaya muat. Tolong nyalain lampu dong. Lampu. Oke, boleh yang di belakang mungkin agak merapat sedikit supaya in frame semua. Baik, kita mulai. Berikan senyuman yang paling manis. 1, 2, 3. Boleh pose lain? Another pose. 1, 2, 3. Oh, oke, apa-apa. Oke, another pose. Sekali lagi for the last freestyle. Okay, everyone, this is the end of today's event, the update and feature of breast surgical oncology. I would like to give my thanks especially for Dr. Denny, Dr. Anna, Dr. Samuel, Dr. Bayu Brahma, and of course to all participants of today's event. We hope today's event provide meaningful update for the future of breast cancer treatment and surgical innovation in Indonesia. I'm Mas Ginawang, and it has been a pleasure to serve as your MC. Thank you.